So simulation again. Oh, your UGS has grown. We've done sim to death. But no, we've got Halden. We've got our young gun with us. We know the crazy stuff that he comes out with. And maybe it's the exciting stuff. So Halden, tell us some more. Tell us about the future.
I'm going to look at a little bit more technology, as if I haven't given you enough already with that crazy EPR thing. This is much less crazy here, just a normal, patient monitor. Vital piece of equipment to be able to deliver physiological information to our candidates about their casualty and to progress the scenario and deteriorate and improve the casualty without having to use the voice of God, the voice of the instructor, to bust up that emotional attachment that we talked about earlier. There are some exceptionally capable commercial devices of these. They are fantastic. But for our course, we just can't afford them. In fact, we could barely even afford one, and we need 7. So here's me with a Hulk, an empty Hulk of a Core Pulse 3 monitor that we acquired for about $100 from the company, and some pre-loved reconditioned iPad minis, lovingly installing it in this dead case. And the result of these, we've got 7 of these. On the far side, you've got our physiological patient monitor with a really cheap app. In the center, simulated ultrasound with the help of some SmackForce friends that helped us out with the app we use, even a podium timer and a, hey, fancy logo at the bottom to help us out. So not quite as fancy technology as the EPR, but some technology nonetheless that can be used for 21st century sim at an appropriate cost.
Well, what about looking into the future? I provide telemedicine. That's what I do as my day in, day out job. And I was thinking, what about simulating from a distance? I mean, that's got to be the goal, right? We've all got distant bases. We've all got places to go and guys who are out there in Sligo while we're in Cork and whatnot. And thinking, how do we do that? You look at this video, it just looks like a simple video in my hospital, which it is, and these guys are simulating, right? But there's one crucial difference. Those monitors are being controlled by Mark, sitting in the UK while we're in Europe. And all it is extremely simple, installed in every operating system, IT control software. You know that stuff where, Apple comes and logs on to you, says, I got your screen? That's all we're using. Keep it simple, folks, and you can actually simulate our man Phil out in Antarctica. Really, really simple, really, really cheap.
So let's move forward with the technology. How come my dad, who's nearly 90, can sit at home with his VR set on and do all sorts of crazy stuff and go to all sorts of crazy places? Why aren't we using this? We're high-tech medicine. We're total at doing the basics well, but no, we want the complex stuff, the scientific stuff as well. Well, we don't all drive Bentleys in Cheshire, unfortunately, but we live very close to the place where they make Bentleys, and this is the Bentayga, and this was actually designed. By the look of it, you might not like it. You may think, yeah, it was designed by a computer. It was designed with virtual reality, and it wasn't just the car. They designed the whole factory with virtual reality. And in fact, you can go to the lab that helped them, as we've done, and you can actually walk around the factory with the set on, with the hats and gloves, and you can actually fit components to the car, and you can actually make the car. And we thought, this is amazing. We absolutely loved it. We had a fantastic day there, but we just thought, how is this going to fit to medicine, though? Isn't it better to actually feel things? All the stuff we were talking about before, making it real with a real person and having the physical contact. So it didn't quite work. But one thing we did learn from them was, if you want to teach a simple core skill, like changing the wheel on a car, or doing a simple practical medical skill, VR can be quite useful for that. But if you're going to do it, and you're going to use VR, it doesn't need to be ultra high definition. It can actually be really quite low definition, like a wireframe diagram. And you can teach this skill, and the University of Liverpool, working with the same lab, have shown that that's just as good, if not better, and obviously considerably lower cost. But we came away from there really disappointed. We thought this was going to be the next big thing for us, was to use VR. But it wasn't. But let's go back to the family, because how come, at home, the kids are doing this? And yet, in the hospital, in the sim lab, in the ICU, we haven't got anything like augmented reality. There may be very few people in this room that have used augmented reality in treating patients or in training. So Halden, is there a future here?
There is augmented reality used in medical simulation, and to see it, we're going to need to just nip back to the sim lab. So here we go into D.Y. Patil's sim lab, and we're about to see the Microsoft HoloLens. That's that space Star Trek thing that these guys are wearing for diagnostic imaging. Inside the torso now, you can see the heart moving. And as they move their probe, you can see the ultrasound image being generated live and overlaid on the actual anatomy. Diagnostic imaging, though, not too hard to put an ultrasound image. What about something else? So here we've got a bit more diagnostic imaging taking place, doing some echo with the image overlaid on the actual beating heart. Now we're putting the TOE probe in, and we're seeing the probe advance. Now we're putting a femoral artery catheter in, and we're actually seeing it thread into a coronary artery. So we're doing intervention with Microsoft HoloLens, live visualizing the anatomy. What about a step further still? If you said, could you deliver a baby with HoloLens? Surely not. You can. There's the baby crowning, and using HoloLens, you can see inside the uterus. You see the external part of the baby is lined up. They're correctly treating shoulder dystocia with McRoberts maneuver. The labor's going to continue to progress. You'll see the uterus empty in time as the baby comes out into the real world. Amazing technology, Microsoft HoloLens. So augmented reality does exist in healthcare simulation. But what are the fallibles of this? It's sure as hell going to be expensive. It's early days for HoloLens, and although those videos look super slick, I bet they weren't taken in one take. It's going to be fragile, and it's going to be fallible. And you've got to be back in the sim center, and hey, you know that box, that Resusci Annie I brought on earlier, that rubber dead thing that actually wasn't rubber or dead? These are rubber dead things again, and maybe that's a regressive rather than a progressive step. So what about using augmented reality on our live actors? Here's an example of doing exactly that. This guy, major incident simulation, super simple, and often a major incident casualty will wear a card with some obs on it or something. Well, all we did was take one of those pre-loved iPads again, install the right apps on it, and create a card with a unique identifier, a bit like a QR code. When you hold the camera over that card, it displays the patient's physiological information that you wish to give the learner. On the left-hand side is an experiment that I was doing. We've actually used this on the course now. Take 40 casualties and try and give all 40 of them one of those simulated monitors. You're going to need either a lot of money or a lot of real monitors, or some pre-loved iPads and this. ECG trace, SATS probe, blood pressure. Patient's not looking too good. And all that is a still image of a LifePak 15 with a unique identifying image, a bit like a QR code in the middle, and a pre-loved iPad. So augmented reality does exist in healthcare. It's early days, and the technology may improve to allow us to access it more easily.
But we still want to use this technology on real people. And we actually want to pay tribute to the makers of Catsuit. I mean, they've gone extremely far, and they've created some fantastic wearables that you could do pretty much everything on. But I think you'd agree that sometimes you can go just this little bit too far. And fine, this is great for surgical training, and it's quite difficult to reset these things if you want to rapidly just take a step back. There's the other thing. I mean, it's a bit unnecessary for the pre-hospital guys. I mean, what are they doing treating a guy with gestational diabetes for? I just don't get it, right? So most of you are enthusiastic trainers with limited resources like us. The future has to be a balance of time, effort, and simplicity. Why not make your own? And that's the concept of the lab. The lab isn't some expensive place or anything like that. It's our garages. Everybody's seen this video at some point. This is totally simulated, okay? It was our first generation Airway Trainer, and really inexpensive. This wasn't made by some company that charged us $1 million. This is made by ourselves. Keep it simple, keep it real. And what you've got here is Halden able to do something as a drop of the hat. We were actually winging it that day. We forgot about we had to actually teach that day. Very low cost, very realistic, very portable, it was in his pocket, very reproducible, and very, very safe. With wearables, the sky is absolutely the limit, as we demonstrated in Dublin. We did this in Dublin, if you remember, on stage. Berlin, we had a few more challenges, I mean, in Berlin, we had to do an ultrasoundable, cannulatable Reboa live on a person. I think we might have pulled that off. Of course, it went a bit further. Lionel actually challenged us, with his ECMO in the street. Could we do real live ECMO using a real ECMO pump that wasn't going to alarm and go crazy on us? That's fair enough. We're challenged in Sydney as well, and of course in Sydney, no, I can't talk about that, can I?
I don't know what you're talking about.
Sorry. Anyway, back to you, Mark.
Okay, so let's get away from the actual running of the sim now. How are we going to get it back to our learning objectives that we talked about before? And something that we've been working with the Intensive Care Society in the UK for the last 4 years is using simulation. And something that I was inspired when I first visited Sydney Hems, and I saw the way they do the sim every day. And I thought, wouldn't that be amazing? We don't sim every couple of months or every couple of weeks. Well, we don't now. Now we do sim every week, if not moving towards every day. And we used the Intensive Care Society delegates to help us. And they gave us basically a shopping list that we were going to use to put forward to build our sims. A top 10, as it were. And it was things that we deal with on a day-to-day basis. It was things that we really don't like dealing with. And it was also some genuine critical incidents that occurred. And from that, we built up this top 10. And these are scenarios that have got multiple competencies to be demonstrated by a multidisciplinary team. So it's everything from hand washing, through putting your PPE on, through setting up your equipment, to ultrasound, and right through this way, putting the line in or whatever it is you're going to do. Everybody is demonstrating witnessed competencies. It's the whole idea of being witnessed. And I've actually got some video of Australia now adopting this as well, the whole witnessed concept. I'm sure Clifford getting younger. Anyway, so witness this whole idea of being witnessed. We don't do the spraying of the silver thing, but we produce what's called a witness competency record for every single member of staff. It starts to grow into an enormous database that we can use. So when CQC come, or we have to do our annual appraisal or whatever, you've not just done the procedure once, you've done it many, many times, and it's on the huge unit database that we're slowly building, the witness competency record. And this allows us to produce a continuous process of improvement, which links into our governance really nicely. And even better than that, it takes us away from the once-a-year mandatory training, going over to squeeze the rubber doll in the research room and get your tick to say that you've done your ALS. It allows us to get away from that. And we can take it further because the staff are now engaging in this so much that we're actually using it on real cases. Why not demonstrate the competencies and have them recorded when you have a real patient? It's going to be a much, much better idea. And we start to build up this huge bank that demonstrates our staff are up to speed. So we've talked a lot about different types of simulation. And I think you're now realizing there's no single simple answer. There's lots of different answers. But what we've hopefully done is to inspire you. Go and throw a pebble in the pond. Throw a sim into your department. Plan it. Make sure you've got clear objectives, but once you've actually done that, it'll start to generate ripples. You'll get your departments excited about it. Don't scare them, engage them and get them involved. And by doing that, and by generating those ripples, you'll start to tick lots of boxes and demonstrate lots of competencies. Thank you. We've got a couple of minutes left. Don't worry, we're not going to storm the building, we're not going to do anything crazy, but what we would like to do is to recognize something.
Yeah, it would be remiss of us at the world's leading pre-hospital care conference not to acknowledge what we consider to be the greatest pre-hospital rescue of all times.
So ladies and gentlemen, please join us in acknowledging the success and indeed the sacrifice involved in rescuing the 12 boys and their coach in the Thai cave rescue.
Thanks, guys. Craig Wiley, Smack News, back again.
Terrifying.
Halden, what's wrong? Okay, so
we just know what
I
we're going to do to you.
I must be honest, guys. The day's not over. Please, can we have some more Slido questions? But there was a very important one. that I thought is quite important to ask is, you talk about this witness competency record, which essentially, from what I understand, is that when you're actually performing a skill and you are there physically doing it on a real patient, someone signs you off. When we do simulations, however, there is an instructor standing back and saying, okay, let me sign you off. How do you see this practically working in our hospitals, where sometimes we are resource constrained, sometimes we don't have someone to stand back and say, great work, you've done it right. There must be loopholes that we can
I'd flip it on its head there, as everybody likes to do to you. I would say our biggest problem is removing staff from the shop floor to go off and train and to go off to do their mandatory training and that sort of thing. And that's a huge cost, both in time and resource. And being able to do it on the shop floor, inevitably, you've got to get the fundamentals in place. You've got to get the basics done. But when it's staff that are constantly revalidating, who are already trained and just need to stay refreshed and stay up to speed, to me, it's a no-brainer. It's a much better alternative.
Do you know what it is, Craig? You've got to make it exciting. Our staff want to simulate in the mornings. And we will arrive in there and, we'll have our typical 75 patients on the corridor on trolleys, and we'll have, everything just jam-packed, chock-a-block. Everybody's exhausted. But we find like the guys have created this little space in the procedure room to go, Jace, do you want to just do a bit of simulation this morning? And actually, it's just our way of taking a step back from the hardships of a difficult shift, both past and to come, and it's just ourselves showing that we can actually keep up to date, that we can actually simulate things, that we can actually progress in our own clinical practice and development.
Halden, any opinion from your side?
Nothing to add.
Okay, with that, signing off. Smack Force News.
Thank you very much.